Welcome again, my colleagues. Are you ready? Hello?
Yes, hello, sir.
Hello. Give me 1 minute. I will answer because today is one of the critical sessions. Uh,
Okay.
okay. Diagnosis, Dr. iPhone, diagnosis of last case. I don't know which last case. See, the case before it was uh, uh, super scan due to renal osteodystrophy. If you mean the case before it was a sclerotic mets. The case that has a sclerotic rib, prostatic sclerotic mets. Okay. No case. We didn't get any case with ureteric stone. It was transitional cell carcinoma. My colleague, I repeat the diagnosis, especially in each case, more than 3 to 4 times. So please concentrate to save our time. Multiple frames and curves in dynamic like Max 3. I don't know what they mean. Multiple frame. يعني I think our colleague here mean when we see multiple images, it is a dynamic. Okay, acceptable. Acceptable. How to differentiate between hypertrophic pulmonary osteoarthropathy and metabolic scan? I will bring one case, okay, to save our time. I will bring one case. Budget is not bilateral and not symmetrical. This is correct. And one of our friend asked, mm, okay, let many question about hypertrophic osteoarthropathy. Okay, class not ended. Class not ended. My colleagues, many question indicate that يعني many of you are not concentrated because I told you 5 minute break. No problem. Anyway, yeah, let's start again, my colleague. Are you ready?
Yes, good evening, sir. How are you?
Evening. Uh, let's start again. 10-year-old patient with left hip pain. By the
Yes, I
way,
have been.
one second, one
Yeah.
second. By the way, I have been presented with a very similar case, but by the way, it was a little bit difficult. It was an X-ray, then bone scan,
Yes.
pelvic. Okay? Yeah.
Okay. I have been presented with frontal pelvic radiograph frog view for a skeletally immature patient with history of left hip pain.
Yes.
In comparison between the both femur bones, I can see that there is areas of sclerosis noted within the neck and proximal shaft of the left femur bone in
Okay.
comparison with the right femur bone. I cannot see any periosteal reaction. Also, I cannot see any cortical breakdown through, and also there is no matrix calcified or chondroid matrix. Appearances are mostly those of non-aggressive lesion. In my routine practice, I want to see the other views if available.
No other view. What else?
Okay. My differential diagnoses are those of non-aggressive lesion. I will correlate with the patient history to see if the left hip pain is especially at night, and if it is relieved by
Yes.
non-steroidal
Yes.
anti-inflammatory drugs. The top differential diagnosis will be those
Doctor.
of
Doctor.
osteodysteoma.
Doctor, 1 second, please.
Ah,
In this question, you must ask the examiner. Ask him, doctor, if the patient has fever, and you must wait from him. And the examiner, by the way, wait from you. He is waiting this question. Okay? Ask me this
yes.
question. Ask.
I will correlate with the patient history to see if there is any
No,
fever
no,
or
no,
any
don't
other.
correlate. No, no, ask the examiner. Doctor,
Yes.
is this patient has
Okay.
fever? No. Second question.
Is this patient complaining of night pain?
Yes.
It is relieved by non-steroidal anti-inflammatory drugs.
No, not three question. Yani one or two question and then give a differential. Okay?
Yes. So my differential diagnosis will be those of.
One second. One
If-
second. Doctor.
yeah.
This is not an OET test. You do like the OET test.
Yes.
Okay. So give me a
Okay.
differential. Mm.
Yeah. Differential diagnosis: osteodysteoma at the top of my list. Because absent of history of fever, less
Okay.
likely to be osteomyelitis.
I will tell you one experience for me. In one
Ah,
Viva, I asked one question for the examiner. It was abdominal X-ray, and really it was in confusing. One question, not my colleague who is annotating. Please, please, there are somebody use the pen. Please don't waste the time of your colleague. Then I ask the examiner one question. The question dramatically changed the scenario. And she answered me, by the way. She gave me a good answer. Immediately, everything is changed completely. Okay?
okay. Okay.
What? See, the most
Yeah.
important, this one. Talk about this one. Mm.
Yes, I have been presented with bone scan for the same patient. I can see that there is
1 second.
increase uptake.
Static or dynamic?
This is static.
Because we have dynamic in the bone scan. What
Yes.
happened?
Yes. First of all, I can see that there is uptake within the kidneys. So this is not likely to be a super bone scan
Okay.
study.
What else?
I can see that there is two
One
areas of.
question, doctor, one remark. From the beginning, we have a localized abnormality. Okay.
Yes.
So in
Yes.
localized abnormality, go directly.
I,
Okay?
I will go. I
Yes.
can see that there is increased uptake seen within the proximal part of the left femur bone,
Mhm.
and it is surrounded by also a lesser degree uptake,
What is the
uh,
name of this sign?
double density sign.
Okay. Excellent.
Appearances are those of
Do, do you want
osteodysteoma.
okay. Do you want anything else in this exam?
Do I notice something else?
Yes. No, no, want,
There is
want. Do you want to
uh,
something else?
um,
This is AB, this anterior, this posterior. What do you want? You must ask for something.
yes, I want to ask for delay maybe or other views such because I think this both are posterior. Maybe I can benefit from the anterior projection
Yes, sorry. Both are posterior. Yes, you must ask for anterior. What else?
to see if there is another sequence such as delay, blood pool,
No, no. From the beginning, this is static, not dynamic.
static. Okay,
Wrong
okay,
request.
okay.
What else?
Previous
Zooming,
images,
zooming,
if
zooming,
zooming.
zoom. See my colleagues. I see by my eyes some remarks of FR, one report about the mistakes that the doctor committed. In يعني I suppose that I was my exam is January. Before that, it was an exam for October. After the exam, the RCR send a report and send some recommendation. The first recommendation is please Zoom. Really, most of the candidate didn't Zoom. Very critical. And the examiner really want from you two things: Zoom and review areas. What happened here?
Here I can see that there is two areas of uptakes, which is representing double density sign.
Thank you, doctor, so much. Next candidate, it was a case of osteoid osteoma. This is a double density sign. Double density, not something else. This is the correct name of this sign. Okay, my colleagues, because
Thank you.
some of us mistaken the name of this sign. I will not tell the incorrect. I will not tell to avoid confusion. This is the same case, I think. The same. Next candidate.
Assalamu alaikum, sir.
Salam. Doctor, this adult male patient with bone pain. Go on.
I am provided with a single static image of the delayed bone scan images, in which I can appreciate multiple areas of increased uptake. Starting from the shoulder, there are bilateral asymmetrical shoulder uptake, more pronounced in the
One.
left
Okay, go on.
humerus,
Sorry, go on.
left humeral shaft, and multiple small areas of uptake in bilateral ribs, in the posterior spine, in thoracic and lumbar spine,
Yes.
in the sacrum, in the coccyx, as well as along the anterior iliac blades. I can also appreciate increased uptake in the bilateral upper femur bones, pronounced more on the
What's your
left
differential,
side.
doctor? What's your
So this is an axial increase uptake. I would like to ask the age of the patient. If the patient is elderly, then I will keep
adult?
the
Adult.
uh, possibility of osteoblastic or sclerotic metastasis from the primary. The second possibility for this uptake, I would,
Give me the primary, please. Tell me about the primary.
sir, in males, the primary is mostly from the prostate, and in female, it is more from the
No,
breast.
I want to in this patient specifically.
So, so in this patient, there is increased uptake in the central pelvis. So this is likely a prostatic carcinoma,
This male or
which is,
female? Male or
sir,
female?
sir, this looks like male.
From the
Uh,
history. I informed you in the history. Okay, doctor, you must speak about the kidney. Is this super scan or not? At least,
so there's mild increase uptake in the kidneys.
no, it is the usual. يعني looks like usual. Okay, so
Okay.
this is super scan or not?
Sir, as I can see uptake in the kidneys, so this is not super scan.
So we must also tell the examiner this note. Okay,
Okay.
thank you
Okay,
so
sir.
much, doctor. This is a prostatic mets. The most important of the mets, it is non-uniform, scattered, heterogeneous in size, in shape, even in uptake. Doctor, I want to ask you one question.
Yes, sir.
If I told you, uh, why is this not a multiple myeloma? The multiple myeloma
Mul-
affect also the spine. Why?
yes, but there is lytic lesions do not uptake the reducer. So myeloma is a lytic process.
So myeloma didn't cause any uptake. You mean that,
Yes,
okay? Why?
yes.
Why prostatic cancer? The cancer. Myeloma is a cancer. Why
Uh,
prostatic cancer cause يعني marked
sir, because the osteoblastic activity will take increase more MDP, but the osteolytic or osteoclast will not take up the
for
tracer.
I will ask you another example. Any
Okay,
most of the metastasis cause uptake. Why?
because of the increased mitotic activity and increased
Uh,
osteoblastic activity.
in another word, which part here? Suppose this is a metastasis. Which
Okay,
part or here in this vertebrae is uptaking the contrast? And here and here.
the central body.
Yes, I mean the metastasis itself or something else.
Sir, I guess the metastatic,
No,
not the normal.
no. See, this is a very important. By the way, thank you. Your answer is good and
Okay.
brilliant. But what happened, my colleague, when a metastasis go to the bone? The osteoblast in the bone itself. Osteoblast is a normal bone cell. Start to be activated. Why? Because it is The metastasis is a destructive process. So osteoblastic activity is a reparative process. Increased activity means increased blood supply, means increased uptake. Because if you see here, the bone scan is technetium MDP. This MDP or whatever, يعني this is another analog, is absorbed by the bone itself. Okay, this clear for you? In multiple
Okay.
myeloma, what happened? Multiple myeloma is a bone marrow abnormality, plasma cell abnormality, not associated with osteoblastic activity at all. So in multiple myeloma, it is logic there are no any uptake because multiple myeloma didn't activate the osteoblast. This clear, my friends? This is the point. This is the most important point. Thank you, doctor, so much. The uptake in the bone is related to the activity of its its osteoblast. So in osteoblastic metastasis like breast or prostate, what happened? Post tumor activate more and more and more osteoblast. Okay, thank you so much. Next candidate. Hello.
Hello, Assalamu alaikum, sir.
Salam. 50-year-old female patient presented with suppose chest pain. What happened
Okay.
here?
So these are spot images, CT scan, chest, which are showing um there is soft tissue density opacification of the right lung, and it is showing with a small area of sparing posteriorly,
Yes,
some air localized seen. So there is suspicion of an underlying mass lesion.
doctor.
Can I see the other images? Okay. So
Doctor.
yeah, so there is a soft tissue density mass which is causing the abrupt cutoff of the right pulmonary vessels as well.
Mhm.
Um,
Yes.
the adjacent ribs do not appear destroyed. So this looks like a lung mass lesion.
Okay. Okay. They do
Okay.
this X-ray.
So,
What happened?
so sir, I'm zooming the image to look at the right hip joint, and there is a lucent area which is involving the greater trochanter of the right femur,
Projection.
and it
By the
looks
way,
like
1 second. My colleague, most of the lucency here in greater trochanter is projectional, and I
okay,
think in Viva in the exam they avoid to bring any lucent lesion here because it is acceptable to be projection. What else?
okay, okay. So there is also a linear lucency noted in the diaphysis of the
No,
femur as well.
no linear.
Okay,
What happened?
okay.
I told you
So
before,
there,
when you see يعني upon X-ray which looks like no obvious abnormality, you must look two items, or you must to exclude or to prove two things. Tell me one of them.
uh, sir, at the periphery of the image, sir, in this case, I can see that there is a symmetrical periosteal reaction
Excellent.
on
One
both
second.
sides and cortical thickening.
Okay, 1 second. My colleague, my advice for all of you, when you see especially limbs, when you see one X-ray, if you expect this is normal, okay, tell yourself I must look at two issues. If you see apparently normal bone X-ray, I think the answer will be within two things. Number one, the density. Search for any differential increase or decrease density in all the bone. Number two, the cortex or the periosteum. I, I, ha-
Yes, sir.
I have been presented with one upper limb and it was the answer. Okay, I was
Right.
struggling
Yes,
too much, and finally it was some periosteal reaction. Okay, doctor.
yes, sir.
So there
Yes,
are periosteal reaction. Excellent.
yes, sir. So this is hypertrophic osteoarthropathy. I would like to see the other limbs as well.
The other
to
limbs.
compare. Yeah, so there is periosteal reaction, which is
What is the name of
symmetrical on
this
the other
sign?
side of the femur.
What is the name of this sign?
Sorry.
What is the
So
name of?
this is the tram track sign.
Okay. What happened here?
So on the bones cancer, next we can see that there is symmetrical cortical uptake, which is noted in bilateral
You didn't
femurs
tell
and
me
the tibia.
for 1 second. You didn't talk about the technique.
Oh,
What
sorry, sir. This is bone scan, MDP bone scan anterior posterior views of the whole body
static or
bone scan.
dynamic?
Sir, this is static.
Excellent. What happened? What happened here? Here.
So yeah, it says there is periosteal uptake in the femurs and the bilateral tibia.
Yes.
So this
Symmetrical
is
or asymmetrical?
so this is symmetrical in the upper bones as well, in the humerus and tibia. Sorry, the forearm bones, radius and ulna.
Okay. So your final diagnosis?
So this is hypertrophic osteoarthropathy, which is causing symmetrical periosteal reaction in the bones
Is
as
is
a result of the lung cancer, the
okay? Is
main
there are any
lung
super
cancer.
scan here?
So the kidneys are not visualized. So this is
What? So one
so there
second.
is faint uptake.
Yeah.
Yeah, there is
What
faint
about this?
uptake on the
Look at
yeah.
the posterior here and here. What
Yes, so
happened?
they are visualized. So this is so this is not a super scan.
Okay. So one colleague asked about the super scan in hypertrophic osteoarthropathy. I think here the kidney at least faint, and here
Yes,
clear. Second,
yes, sir.
how to differentiate between both of them? Number one, by history. Number two, X-ray. Number three, in the this isotopic scan. Look here, what happened. يعني it looks like similar, by the way. يعني I agree with you, but at least there are no super scan. At least.
Yes, sir.
Number two, look at the skull and the mandible.
Yes, sir. There
I
is
think
uptake
the
in the
mandible
skull.
is normal, skull is normal. Okay.
Sir, in
See,
the
yes,
third, fourth image.
ask me.
Sir, in the third, fourth image, there is there not any uptake in the skull?
Yes, there are, but see, it looks like symmetrical. Looks like
Okay.
symmetrical. And you see the mandible. What happens for the mandible? Nothing.
Yeah, there is slight uptake in the, okay. So I thought, sir, later images.
Yeah.
Okay.
In my opinion, my colleagues, even the examiner in RCR are not expert in nuclear. So don't worry. I think Dr. Ismail and Dr. Khan, everybody are telling you are lucky if you are presented with a nuclear. Why? He will give you the most common. He will not go in depths
Mm.
because he didn't know the depths like us. So, in my advice, don't go in depths beyond the RCR in nuclear. Don't waste your time. And the same in breast. Breast case is a gift for you because he will give you breast to diagnose cancer. Nothing else. 90% of
Right.
them. Thank you, doctor, so much.
Thank
Next
you, sir. Thank
candidate.
you, sir.
السلام عليكم sir.
Alaikum assalam. 1 second. There are 3 questions. Sorry, يعني in this session I will answer the question because يعني the nuclear is very confusing for all of us. One question. This is osteoblastic metastatic. Then why this is there are no super scan? Because the patient is lucky. This is the answer. Doctor, thank you for this question. She asking about the case before this one. It was a soup, I think this one. It was a metastatic prostatic metastasis. Why there are no super scan? I think you can consider the amount of metastasis. Maybe I just guess. Maybe there are no extensive metastasis to the limit that takes up يعني prevents the kidney from its uptake. Maybe. Okay, and another reason, you will not see all the cases like the book. Okay, my colleague, why we diagnose this as a prostate? Because he is a male. Really, this is this is the main cause. We didn't have a prostate ultrasound. We didn't have anything other than from the history. This is the logic answer. Okay, I think this is the next case. 7-year-old male patient presented with left leg pain. Go on.
So I'm presented with the static images of bone scan for a 7-year-old patient present with the left knee pain. In the blood pool phase, I can appreciate that there is focal increased tracer uptake involving the medial aspect of the distal femoral condyle. So I want, this is the flow phase, blood flow phase as well on my left hand. And the blood flow phase, there is a progressive increase of the radiotracer uptake
Excellent.
as well. So in the triphasic scan and the blood flow, blood pool, and I think the third phase is the delayed phase.
Yes.
If there is hot area or increased uptake on all three phases, I will think about a first infective process like osteomyelitis. So I want to ask about the presence of fever or constitutional symptoms in addition to the pain.
Yes.
And I want to correlate with plain radiograph, although normal radiograph will not exclude osteomyelitis, as the nuclear changes will precede X-ray changes by about 2 weeks. I want to correlate with the bilab test also, inflammatory markers, to confirm my finding of left side acute osteomyelitis.
Okay. So conclude.
Conclusion, triphasic bone scan of both knee joints in a child with the history of left knee pain shows increased tracer uptake of the left medial distal femoral condyle on blood pool and blood flow phases, suggesting acute left distal femoral acute osteomyelitis.
Excellent. If this chronic, what is the expected picture? And by the way, it is beyond the FRCR. But by the way, if this chronic, could you think you will see all this uptick, or you will see some photopenia here?
No, I think because the presence of sequestrum and dead bone, there will be cold spots instead of hot spots.
Thank you, doctor, so much. So our doctor said that we see a lesion here that show uptake in all phases. This is dynamic. Why? Because he gave us timing, and there are multiple image. Very easy. So this is dynamic bone scan. When you see dynamic bone scan, put in your mind one of two diagnoses. Either osteomyelitis or what is the second one, my doctor? Hello? Doctor.
Sorry? Yes?
What is this? Two lesions take show uptake in the three phases of bone scan. First one, osteomyelitis. Next one.
Three phase.
Mm-hmm.
It's not in my mind now. I'm sorry.
Stress fracture.
Stress fracture, yes.
Okay. Thank you, doctor, so much.
Thank you so much.
My colleagues, about bone scintigraphy. It is very important. Give us, I will take 5 minutes to revise our knowledge. I think many of us know it, but no any problem of if we revise it again. That the tracer is technetium diphosphonate. Okay, my colleague, what happened in dynamic? Most of the bone scan is static, like this one. This is static, okay? Only one AP and one PA image. But something like the previous case, just shown one, is dynamic. In dynamic, what happened? We have three phases. Flow phase, blood pool, delayed. Flow phase, any uptake in flow phase, it means increased perfusion. Blood vessels increased. Increased blood vessels in the bone, either by stress fracture or osteomyelitis. Then this is blood flow to a particular area. Then the blood pool phase. This is obtained 5 minutes. 5 minutes. This is due to inflammation. Any inflammation, if you see in the blood pool, I mean after 5 minutes, any contrast, any uptake, this is means there are inflammation. Okay, if you take a photo between 2 and 4 hours, this is a delayed phase. A delayed phase. Delayed phase, you may see some urine excretion, and you may see the urinary bladder. Okay. Anyway, this is due to osteoblastic activity, new bone formation. And by the way, all the static bone scan are delayed phases in 2 to 4 hours. Okay? All bone scan for metastasis are static in delayed phase. So it represents the osteoblastic new bone formation. Okay, my colleague? The only pathology that show uptake in the two, osteomyelitis or stress fracture. The delay 24 hours, this is not common. I think this is beyond our scope. So at least if the examiner ask you 1, 2, 3, and you can mention the significance of each one. This is blood flow. This is due to inflammation, and this is represent new bone formation. Okay, my colleague. Next candidate. Next candidate.
Yes, good afternoon, doctor.
Afternoon. Doctor, give me, see 1 second. Give me one. Are you ready?
Yes, doctor.
My colleague, one question in the chat box. What about the cellulitis? Cellulitis in the soft tissue. I wanted to ask the candidate who asked this difficult question because I'm not expert, but I know this answer. Doctor, do you think, by the way, this is very good question, really. Thank you. Thank you so much for this question. I will answer you now. See my colleague. This is the last one. By the way, because we are not familiar to this one, to nuclear, it looks like difficult. Here, this is osteomyelitis, and I just have been told you. Sorry, I have told you. This is not correct grammar. One, 1, 2, 3, all phases. There are uptake. Even here, mild, moderate, in the delayed, okay, uptake. All of this uptake. What is the differential diagnosis between cellulitis and the bone? What will happen? Cellulitis is an localized inflammation. Almost you will see here in the flow phase and the blood pool, you will see some uptake. But in cellulitis, there are no osteoblastic reaction because cellulitis is a soft tissue disease. So you will not see here and here any uptake. So cellulitis will show in the first two phases, but will not show uptake in the delayed phase. And this is very good differential point between cellulitis and osteomyelitis. Besides the X-ray, but again and again, stress fracture like osteomyelitis. I think it like. Why? Because it's in a stress fracture, there are a reparative osteoblastic reaction. So you must see in a delayed uptake. Doctor, how we differentiate a stress fracture from osteomyelitis? By clinically, okay? Even ask if the patient has fever or not. Do CBC. Okay, my colleague? Very nice questions. Thank you. We finish this one or not?
No, no, doctor. This is my turn.
Oh, okay. Sorry for interruption, but really the most important of today is to answer all the concerns. I think we are recording. We are recording. Doctor, this... What happened? Oof. 1 second. I make a mistake. What happened? What happened here? 90-year-old female patient presented with left kidney abnormality. Go on.
Okay, this is a max 3 renogram for both kidneys for 80-year-old female patient. I can see that the left kidney shows photopenic area within the pelvis. And the right kidney appears looks like mal rotated.
Very difficult, doctor. Uptake, there are uptake or not?
There's uptake, but I can't
Okay.
see the looks
Okay.
like the normal one.
Yes, yes, yes. See, by the way, this is not anatomically oriented at all.
Mm.
So there are a photopenic area. You are very correct here. You are excellent. Okay.
Uh,
This is right or this is
this is the left one.
left one. Okay. By the way, it may be rotated. I may agree with you, but don't go beyond the RCR and don't insinuate yourself in too much details.
Okay.
Okay. What
Okay.
happened here? First, I wanted to show you this one. Okay, tell me what happened.
Okay. This is bone scan. HDP. I can see that there is this is the left. Okay. There is a right increased uptake in the right hemipelvis
Okay, excellent.
and in the sternum as well.
Okay.
I can see both renal uptake, so this is not super scan.
Okay.
And there is also increased uptake in the left knee.
Don't worry, this is degenerative.
Okay.
Or there are something in the joint. Don't worry about it.
Yeah. Okay. And there's also uptake also in the elbow joint. I can see there is increased uptake and
Where is
increased
your
uptake.
doctor? Where is your main concern?
My main concern in the uptake in the pelvis and the skull as well.
What
There's
happened? Tell me, what happened? There are uptake and what else?
um, enlargement of the hemipelvis.
Brilliant.
So there's now 3 concerning uptakes, one in the skull and the sternum and the right hemipelvis. So I think this raised the concern of being budget.
Brilliant.
So I would like to correlate with the alkaline phosphatase level and
You didn't tell
previous.
me. You didn't told me. Super scan or not?
No, I have told. I can see that the kidneys. This is not a super scan.
Okay.
So I'm concerned about.
What do you want else?
Sorry.
What do you want else from the examiner?
If there is zoomed view.
What?
Zooming view to check the zoomed view.
Okay. In which part?
the pelvis and the skull.
Brilliant. What happened here?
This is delayed bone scan. I can see there is increased uptake in the
Static. Doctor, static bone scan.
okay,
Mm.
static bone scan. There's increased uptake in the cortex of the skull and
And
mainly in the frontal and the sternum.
okay, and the most character.
Yes, this is the frontal
Yeah.
part
Uptake and what about the
and
size?
the enlargement of the cortex,
This is
cortical
this
enlargement.
is يعني very related, closely related to
Okay.
budget. Okay, so
Uh, s- so okay, this is the X-rays,
after each
which confirm
after each bone scan, you must request X-ray. What
correlate with
happened
X-rays.
here?
Okay, there is enlargement of the right hemi pelvis with
And
increased sclerosis.
where? Where
Uh, ra-
exactly?
in
What?
the right hemi pelvis, in the iliac and acetabulum.
Yes, where is exactly? In the cortex
The
or in the
cortex,
medulla?
yeah, in the
Oh,
cortex, no, in the cortex.
excellent. And the sternum
The
and
sternum as well. And there is cortical enlargement of the skull, giving a cotton wool appearance of the
yes,
budget.
brilliant, doctor. Doctor, this is the cotton wheel. Why? Look here, ill-defined considerable area of sclerosis. But in comparison to the salt pepper appearance, it is a small, in salt pepper appearance, a small lytic and small sclerotic, small. But here, see, sizable.
Mm-mm.
What is this? What is the name of this area?
Uh, circumscript,
Yes,
circum, osteo,
osteoporosis.
circumscripta. I can't remember the name, sorry.
Yeah, osteoporosis, some circumscript.
Yeah, osteoporosis circumscripta.
So the most important is being osteoporosis, not some script.
Circumscript, okay.
Some script means well defined, sharp defined, like something like this. Osteoporosis, some script. So, and see another differential point. Look mainly at the outer table. The most important is second. Little bit at least second. Don't look at the occipital. Look here. Here is second. And even the inner table is significantly second. So it is almost a budget disease. Somebody will ask me, doctor, I am confusing between budget and about the skull and hyperparathyroidism. give يعني in the worst plan give both differential but both يعني tell the examiner that the first one you suppose the first one is like this and give him a cause and you can ask the examiner about the age about anything else. Okay, is this
Mm.
patient for example has renal failure? I think more than 90% of the cases of hyperparathyroidism is due to, even in the exam, due to renal failure. So, my friends, it was a case of polystatic disease, Paget, polystatic Paget disease. Thank you, doctor, so much.
Thank you, doctor.
Doctor, do you know, this is a difficult question. What is the underlying pathology or mechanism of Paget disease?
Uh,
What is the abnormality?
pathology itself.
One word, one very simple word. There are many theories, but tell me at least very simple word.
Um, it's increasing the osteoplastic activity.
What about the osteoporosis some script?
Ah, okay.
Mm. In,
Mm,
do you know there are turnover of the bone? Turnover. This
mm, mm,
mechanism is disturbed. A very simple answer. Very simple. A budget is a metabolic disorder. Okay? What happened in it? there are abnormality in the turnover. Very simple. Okay,
Mm.
despite there are many explanation, many explained pathology, but tell the examiner the pathology here is due to the turnover. Uh, If I ask you what is the underlying pathology of um, fibrous dysplasia, by the way, in budget is due to turnover, and it is related to elder. In fibrous dysplasia, it is the opposite. It is related to younger. So the process is opposite.
Mm.
Formation. Abnormal bone formation in fibrous dysplasia. The bone has a specific lamellated pattern. This is the normal. In fibrous dysplasia, this is disturbed. Instead of the lamellated cortex, okay, and the normal marrow, it is replaced by Wolvian bone, abnormal immature bone. Very easy. Okay.
Okay.
So in budget, it is a problem of turnover. Okay. In fibrous dysplasia, it is a problem of bone formation. The normal bone is replaced by immature bone, Wolvian bone. So in fibrous dysplasia, it is ground glass. Thank you, doctor, so much. Next candidate.
Doctor, sorry, can I ask a question regarding the photopenic area in the kidney?
Yes.
Was it a renal lesion, or how it is related to budget?
How it is related to it may be a site finding. 1 second.
Mm.
I will see the radiopedia because I don't know the answer. I will answer you. Wait
Okay, thank you.
1 second. Next candidate, are you ready?
Yes, sir.
Okay. See,
Is
doctor,
this
they didn't told us anything about this area. 1 second, I will see the CT.
hello?
Doctor, you can start. You can start here.
Okay.
This is a
Uh,
65-year-old male patient with
uh,
prostatic cancer. Tell me.
Good afternoon. I'm presented with a static image of bone scan of a 65-year-old male patient with prostatic cancer. I can see that there are multiple areas of uptake in bilateral clavicles, skull, ribs, sternum, bilateral, both pelvis,
Yes.
bilateral femur.
Yes.
Um, there are no uptake in kidneys, so this is a super scan.
Brilliant.
So,
Your diagnosis?
uh, so my diagnosis would be this can be osteoblastic metastasis from prostatic CA,
Yes.
or
What's your next step?
my next step would be I will urgently refer. I will inform the referring physician and then
Yes.
refer the patient to oncology MDT team,
Mhm.
and then undergo the CT scan of chest and abdomen to look for other metastatic areas, and do blood PSA to see that whether the disease has recurred back or not,
Doctor,
or is there any residual. Yes,
doctor,
yes, sir.
in your opinion, what is the lines of treatment of prostatic cancer? Tell me.
If it is in the early stages, then we would go for radical prostatectomy, and
What
then
else?
if
Yes.
it has passed this stage of bone mets, then I think, sir, it's hormone therapy.
What else?
Uh,
Do you know about the brachytherapy?
no, sir.
The brachytherapy, they insert some radioactive isotopic material inside the prostate itself.
Okay,
Uh,
okay, sir.
Thank you, doctor, so much. This is a super scan due to metastasis. Why? It's mainly axial, heterogeneous, variable in size and shape. Okay.
Mm.
And
Yes.
somebody will told me, doctor, this is in the peripheral skeleton. No, this is in the proximal appendicular skeleton. Why? What,
Mm.
doctor? Why the metastasis is mainly confined to the axial skeleton? Why?
Because it metastasizes through the Batson plexus of veins.
Yes,
So
يعني I
it
mean,
goes up.
what type of bone marrow here?
Okay, it's yellow.
In the axial, yellow or red?
It's yellow, I think.
No,
And
no. Yellow or red?
okay,
Not yellow.
red.
Red bone marrow. طب why the
Okay.
metastasis go to the red bone marrow? Because it is highly vascular. And the
Okay.
proximal part of the limbs still have red bone marrow. That is why it is in the axial and the proximal skeleton. Dr. Nagam,
Okay.
do we have a
Okay.
candidate or we finish
Thank
our?
you, sir.
Oh, thank you,
There is
doctor.
Thank you,
only
sir.
one from the extra list, and we are done then.
Okay. Doctor, this patient, next candidate,
Yes, sir.
80-year-old male patient, tell me what happened.
Okay, so I've been provided with a bone scan. I can see that there is the high uptake in the proximal left tibia, involving the tibial epiphysis, metaphysis, and also the proximal shaft, and
Yes,
it appears more towards the cortical region.
yes.
Uh, there is no abnormal uptake in the rest of the bones. So, given this raised uptake in the left tibial proximal region, I am thinking of an infective etiology. I would ask for the
Do you think,
history of the patient.
doctor, 1 second, do you think the infection will,
So, I'm thinking
for
of
1 second,
an
give me my chance.
osteomyelitis in the tibial region. If there is
Doctor,
history of fever,
give me my
okay,
chance, please, doctor. 1 second. Could you think,
okay.
could you think the infection will draw the tibia? See, like the normal anatomy? No, this is number one. And you forget the history. You forget the history.
Okay. It is 80 years old patient. So given the involvement of a single bone on the left side, I am thinking of Paget's disease.
What's your
Um,
next
there is
step?
also
Next
there is
step.
also I would correlate with the radiograph of the patient if
This is
there's
the
history of
radiograph.
if
Tell me what
okay.
happened here.
So I can see that there is a lucency in the proximal tibia with thickening of the trabeculations and the cortex. So this correlates with the Paget's disease, given the old age and lucency with the thickening of the cortex and trabeculations. So
Thank
this is more
you.
towards the Paget's disease.
Thank you, doctor, so much. It was a Paget disease. My colleague, this is a tibia. This is not not
So my
localized.
diagnosis.
Yeah, Paget, thank you. This is not a localized tibial pathology. Almost most of the tibia. Second cortex. By the way, this is when you see something like this in any limb, put Paget until proof otherwise. Okay? And correlate with X-ray. This is degenerative. Degenerative. I think many degenerative changes, especially in old age. Dr. Nagam,
Yes, sir.
can you take your slot, please?
Okay, thank you. So
Okay.
I'm presented with ultrasound study of the thyroid gland. It
Yes.
shows diffuse heterogeneous enlargement of the thyroid gland involving both lobes and the isthmus.
Yes.
I would like to check the rest of the images, checking for vascularity, nodules, and
Yes.
cervical lymph nodes. Yes, it shows increased vascularity, denoting acute thyroid parenchymal inflammatory process.
Okay.
I would correlate with the patient's history. I would check
Doc,
for the hormones.
1 second.
Yeah.
This is the right lobe. This is the left lobe. Okay?
Okay, yes.
And this is grayscale. Hmm.
Okay.
So give me differential diagnosis.
It could be Hashimoto thyroiditis.
No. What else? Hashimoto must be element of heterogeneity. Correct?
Okay.
I agree with you in very early stage of thyroiditis, it may be homogeneous, but commonly Hashimoto is يعني must have some heterogeneity. But this is homogeneous. What else?
Okay, so there are no nodules. I think then it would be like reactive.
What other
Th-
diseases that the thyroid is hypervascular, enlarged, homogeneous? Homogeneous.
Okay, it could be just as a response to parathyroidism, or I mean hyperthyroidism.
Yeah. What type of hyperthyroidism? There are many.
Okay, there are. Yes, I can remember. It could be due to like Graves' disease.
Excellent. What is this?
This is thyroid scan.
Yes.
It shows increased uptake in both thyroid lobes.
Homogeneous, diffuse, or not?
Yes, it is homogeneously, diffusely involving both lobes and isthmus,
This buzzword,
showing.
1 second. This buzzword is very critical. Why? Homogeneous diffuse means, and the homogeneous diffuse means Graves. Yes, what else?
Okay. Uh,
Hmm.
so yes, this is.
Yeah, tell me.
I can detect. Okay, there are few foci of uptake seen in the upper sternum, at the sternal notch.
No. No. This is the suprasternal niche. This is a marker.
Yes.
Yeah, see.
Okay, and
Don't worry, we will give in the next tomorrow. I will give a good background about thyroid. So your final diagnosis.
it's Graves' disease,
Thank you.
Graves' thyroiditis.
Okay, thank you for all of you so much. I have some question. Toxic. Okay, toxic but Graves. يعني see, better to use Graves. Somebody send me one question. Sir, lymphoma bone mets can give same bone scan appearance as prostatic cancer? Sir, I wanted to answer you that I'm not expert in nuclear scan. Let's search, search and I will search, to give you an accurate answer. Okay? Let both of us search and give an accurate answer. Okay? Sir, how it is Graves? Okay, Graves. From the ultrasound. Look, my friends, enlarged, hypervascular, homogeneous. This is homogeneous, by the way. This is homogeneous. See? Homogeneous hyperparathyroidism. It is Graves until proof otherwise. Okay, my colleagues? What else? Diffuse goiter. Goiter is a general term. Goiter means enlarged thyroid. Okay, my colleague? Under the goiter there are many causes and syndrome, not syndromes, many causes and disease. Goiter may be caused by nodules, by tumors, by Graves, by Hashimoto, by even in thyroid abscess. Goiter means enlargement of the thyroid, nothing else. Thank you for all of you. Really, thank you, Dr. Nagam, so much. Special thanks to our senior, Dr. Nahla. She support us so much. She gave us yesterday many valuable advices. Thank you for all of you. Listen well to this lecture. Please. Another question. How is it homogeneous? It looks like heterogeneous. No. Doctor, this is harsh image. What mean by harsh? The type of ultrasound. See, doctor, Siemens ultrasound gives the same harsh image. What means by harsh image? The image is not soft, not soft. Look here. This is the skin and subcutaneous. It looks like some echogenic nodules, similar to here. This is a harsh image, but generally all the thyroid is similar. Okay, and this is a blood vessel. This blood vessel, look, see, blood vessels. Generally, by the way, if you told the examiner, doctor, it is maybe thyroiditis, maybe Graves' disease, he will be happy. Okay, this is not a matter of conflict. Okay, my colleague, and finally he will do his labs. 90% of the diagnosis in thyroid depend on labs, and all of us know that. Please don't go too much inside dilemmas in anything beyond the scope of our target. Okay, my colleague, this okay. I am agree with you. It may be thyroid, but finally we follow the radiopedia. It is Griffiths. Okay. Thank you, doctors, so much. Thank you. Okay. See my colleague here, mildly heterogeneous. Okay, no problem. The Radiopedia said it is a mildly heterogeneous. But what I meant, it is not the same heterogeneity of Hashimoto. I will show one Hashimoto here. That is what I meant. Hashimoto's thyroiditis. See my colleagues. I wanted to show you in Hashimoto. The gland is very heterogeneous, more than Graves. See here, a big difference, a big difference. That is what I meant, my colleague. See, what's your opinion? Hmm. What's your opinion? Do you think this is the same echogenicity of Graves? I think a very big difference. At least you can swear 100% this is markedly heterogeneous. But look here. Okay, it is fine, mild heterogeneous, but almost not the same. Big difference. Okay, my colleagues, if you give the examiner two differential, two logic, he will be happy. Thank you, doctor, so much. Let's meet tomorrow. Thank you, Dr. Anagam.
Okay, thank you, Doctor, so much. Appreciate.
Thank you. Special thanks to Dr. Omer and Dr. Amiga. They help us by their effort. They spread the link today, and see today many people attend and they get many benefit. Thank you.
Thank you, sir. Thank you so much.